Hi there and welcome. Whether you're a family member, friend or professional carer, your role in supporting people during the hospital stay is incredibly important. Today we're going to talk about something that often gets overlooked but can have a major impact on a person's health and recovery. This is delirium. The good news is that with the right knowledge and approach, carers can provide a vital role in both identifying delirium and helping manage and reduce its effects. In this session, we will cover what is delirium and how to recognise it, what causes it, especially in the hospital settings, and how you, as carers, can help support somebody with delirium. Finally, some practical tips on creating a safer, calmer environment for recovery. Our goal today is to empower you with the understanding and tools you need to feel confident and support in your role, especially when things become confusing or unpredictable. So let's get started. So what is delirium? Delirium is a neuropsychiatric syndrome that often occurs in the hospital. Delirium is a sudden change in a person's mental state that can cause confusion, disorientation, and difficulty with thinking or concentrating. It can be really frightening for someone experiencing it and equally distressing for those trying to support them. The exact cause is unknown, but there are some risk factors associated with this, such as recent surgery, this might be due to pain medications or recent anesthesia, underlying diseases or medical conditions such as dementia, constipation or infection, and chronic fatigue from poor sleep in the hospital. There are three main types of delirium, the first being hyperactive delirium. This type of delirium is characterized by symptoms like restlessness, agitation, rapid mood swings, and hallucinations. It's often easier to recognize than other forms of delirium because the symptoms are more overt, although it is less common than hypoactive delirium. So some symptoms of this are, as we said, agitation and restlessness. This might be pacing, fidgeting, or an inability to stay still. Mood swings, rapid and unpredictable changes in mood, which could include fear, anxiety, or anger. Perceptual disturbances such as hallucinations and delusions. Behavioural changes such as refusal to cooperate with care, being combative or uncooperative. Hypervigilant, so being excessively aware of or sensitive to the immediate environment. And have sleep disturbances, so difficulty in sleeping or disturbed sleep pattern. The second type of delirium is hypoactive delirium and is characterized by a lack of energy, being withdrawn, and reduced responsiveness. Symptoms include being lethargic, sleepy, withdrawn, and having a reduced appetite. This delirium is often overlooked because the person may simply appear tired. The person may be unusually sleepy, sluggish, or tired. They may move around less and interact less with the world around them. They may struggle to follow conversation or be easily distracted, and the person may seem withdrawn and less responsive to their environment. Therefore, they may eat and drink less than usual. The third and final type of delirium is mixed delirium, and it's a form of delirium where a person alternates between symptoms of hyperactive, such as agitation and restlessness, and hypoactive delirium, such as lethargy and being withdrawn, and this can even occur over a course of a day. Symptoms of delirium. The symptoms of delirium can be broadly categorized into three key domains. Cognitive symptoms, such as confusion and disorientation, possibly not knowing where they are, what time it is, or who people are around them. They might have difficulty concentrating, be easily distracted and unable to focus on a conversation or a task. They might have memory problems, having difficulty remembering things or recent events, and they may have disorganized thinking, perhaps rambling in conversations, have unclear speech, or difficulty expressing their thoughts. Perceptual symptoms, so these include hallucinations, so possibly seeing or hearing things that aren't there, or delusions, holding on to beliefs that are not true or feeling like people are trying to harm them. This is a form of paranoia. They may experience emotional and behavioural symptoms, such as mood swings, sudden and dramatic changes in their mood, restlessness or agitation, pacing, an inability to stay still or becoming aggressive or withdrawn. They might have drowsiness or lethargy, being unusually sleepy or less alert, and they may experience out-of-character behaviour, acting in ways that are unusual for them. A poor sleep-wake cycle is a hallmark symptom of delirium. This disturbance is usually bidirectional, meaning that sleep deprivation contributes to delirium, and then the delirium in turn worsens sleep, potentially creating a vicious cycle. It is associated with altered melatonin rhythms and disrupted circadian rhythms, and is a core feature that can help people identify and predict delirium. So how do these manifest? So they might have daytime drowsiness. Patients might be very sleepy during the day, taking naps, and this is a key indicator. They might have fragmented nighttime sleep. So sleep at night is often short, disturbed, or broken. They might reverse their sleep-wake cycle. So some patients show a complete reversal, being awake during the night and asleep during the day. And they might have disrupted circadian rhythms with a loss of day to night variation in their symptoms. And this is often linked to the altered melatonin levels. Factors that can contribute to this disruption are the hospital environment itself. Factors like noise, unfamiliar surroundings, bright lights, and frequent medical interventions in hospital, they significantly disturb sleep. Medications such as sedatives or other medications used in the clinical setting can interfere with normal sleep. They might have underlying medical conditions such as acute illnesses, pain, or anxiety, and these all predispose people to poor sleep and delirium. And as we said before, this then is a bidirectional relationship. So sleep deprivation triggers the worsening delirium, and this goes round in a circle. Prevention. It is the multidisciplinary team's job to identify people at risk of delirium. For example, a nurse might notice that the patient is more sleepy. A pharmacist might notice that they're on high-risk medications, and the doctors might notice a history of delirium. But also, you know your loved one the best, and so if you have any concerns about changes in behaviour, then please raise them to a member of staff. The acronym PINCH-ME stands for Common Causes of Delirium and is used by healthcare professionals to identify triggers for sudden confusion in a person, especially in the elderly. The medical team will ensure the following are completed to reduce the risk of developing delirium or to look for possible causes of the change that they've seen on the ward. First of all, they will identify and manage any pain. They will treat the underlying cause of the infection, such as a chest infection or a UTI. They will encourage good oral intake and nutrition. They will try and treat constipation and ensure bowels are opening regularly. They will ensure good fluid intake. They will make sure that all their regular medications are being taken and review medications to see if there's something that could be contributing to the symptoms of delirium. And we will all think about the environment around them and how to create a good environment for the patient. So what can we do? To help settle delirium, we want to promote orientation and feeling of comfort for the patient. We want to reduce noise where possible. Provide stimulation and engagement in familiar routines and activities such as reading the newspaper, completing puzzles, reading or walking. Ensuring that they have their sensory aids. Life is hard enough in the hospital without being able to see or hear. Ensuring that they have their glasses and or hearing aids with them and that they are on. We want to encourage oral nutrition and hydration. We want to make sure that their bowels are opening regularly and if not, provide medications that might aid this movement. We want to ensure that patients are staying active, sitting out in the chair daily where appropriate and moving around the ward. We want to encourage healthy sleeping habits. The ward might ask you to help complete the This Is Me document. This document helps care staff see the person behind the diagnosis, their history, their preferences and their personality, which supports a more respectful and patient-centred approach. Having this information can reduce confusion and distress when they're in an unfamiliar environment, such as the hospital. Sometimes we like patients' families to bring in photographs for the bedside. Hospital can feel really clinical, impersonal and frightening, especially for our elderly patients. Photos offer an emotional warmth, reminding patients that they are loved and not alone. They can help reduce anxiety, loneliness and fear, especially during long stays or if family can't visit as often. And we also like people to bring in familiar items of clothing or items in general. Everyone has a pair of favourite shoes or slippers or a favourite cosy jumper, and these items can help your loved one feel more at home, relaxed, and therefore less muddled and comfortable. In some cases, the medical team may suggest use of medication to aid delirium, particularly to help sleep. These medications are only considered if there is severe agitation or psychosis, or when non-pharmacological methods have failed. Some important considerations for this are that they are for short-term use. If medication is prescribed, it's typically for short duration, generally a week or less. They are placed in low doses. So the aim of the low dose is to calm the person and not sedate them. The risks versus benefits of these medications should be discussed with patients and their carers. We need to ensure that contraindications are considered, and we need to make sure that these are in line with clinical guidance. So as the delirium practitioner, how can I help? I can help educate family, friends, patients and staff on delirium. I can help to assess patients for delirium and give clinical advice on treatment. I can help support patients who are experiencing delirium on the ward and suggest practical strategies to help with behaviours. And I provide holistic care and advice to patients, relatives and carers, and can signpost to community services as needed. We also have an amazing service in the hospital called Caring for Carers, who are there to support family, friends and unpaid carers of our patients. They can listen to and support with any queries or concerns you have relating to your role. They can advocate and liaise with clinical staff on your behalf. They can provide information about community support services, and they can also provide emotional support during these difficult times. Delirium is common, serious and often preventable. With your continued vigilance, compassion and support, you make a real difference in early recognition and recovery. You are not just a family member, you are a vital part of the healing journey. Thank you for everything that you do. Let's keep working together to protect and support those at risk.